So I got this amazing book from a good friend of mine, and I was just flipping through it for the first time and came across neck trauma and thought, why don't we talk about it? Because this is such a great illustration, and then we're talking about airway emergencies here too. So there are 3 zones of the neck when we're talking about neck trauma here. So zone 1, so we start down at the clavicles here, and basically we're working our way all the way up to the skull base, okay? The skull base ones really are tricky. I've made a video on that before because this is one of those very hard to get to areas in surgery. But for all of them, you see here that our imaging study of choice is going to be a CT angio. Now, when do we go straight to the operating room is a great question. And what we have here are the, quote, hard signs of vascular trauma. So someone has an expanding neck hematoma, a bruit, active bleeding, stridor, any of these things are going to really prompt me to secure that airway and then take that patient straight to the operating room. Now, speaking of securing that airway, so A, in our primary survey, we're talking about intubation. So some people will argue about this saying, but it doesn't hurt. It does help that if your GCS is less than 8, you should intubate. So our go-to is an orotracheal intubation with an endotracheal tube. And then how do we confirm that that tube is in place? Always, always, always end-tidal CO2 waveform capnography. Then on here, we talk about a few different surgical airways, right? The cricothyroidotomy, lots of videos on that. I like to just use a blue rhino percutaneous tracheostomy kit when I have a surgical airway emergency. I'm able to do that extremely quickly, but that's just something nuanced that I've developed in my particular skill set over the years. But your go-to for your surgical airway is going to be your cricothyroidotomy. We can also do a nasotracheal intubation, and that also works well for patients with angioedema, big swollen tongue. Maybe they took an ACE inhibitor. That would be a good test question there. You load your ET tube on a bronchoscope. You put the bronchoscope through the nair, down through the vocal cords, and then use that bronchoscope as basically a super advanced bougie. And it works really well for a complex nasotracheal intubation. Have your anesthesiologist at the bedside, your emergency medicine doctor, and your trauma surgeon for that surgical airway. But great resource, great book. You guys should check this out. This is your guide for step 2. Awesome, awesome resource.